All right, everyone. Well, just in the interest of time, thanks so much for for attending this TUSM Global Health Seminar. This is part of a generally monthly Global Health Seminar series sponsored by the School of Medicine, by the Global Health Faculty Council, and by the Tufts Center for Global Public Health. So today's seminar is One Health in Northeast India, Insights and Perspectives from the Field. And we're very pleased today to have Dr. Rajiv Sarkar here to speak on this topic. And one of the things we've tried to do in the seminar series is feature voices from low and middle income countries who are doing work on the ground in global settings. So we're very privileged actually that Dr. Sarkar happens to be coming through Tufts today and was willing to give this seminar. So Dr. Sarkar is an associate professor at the Indian Institute of Public Health in Shillong, India. He is an epidemiologist with more than a decade of academic and industry experience, conducting community-based studies in India to assess epidemiology, transmission, and control of infectious diseases in remote endemic communities. He's authored over 80 peer-reviewed publications in national and international journals. He's an editorial board member of the Journal of Public Health, associate editor of Epidemiology Infection, and an academic editor of PLOS Global Public Health. And I should note as well that Dr. Sarkar, we've been very privileged in prior years that Dr. Sarkar has spent time contributing to the Tufts community previously and training at Tufts, so that we're very proud of that. I would like, just on a personal note, to have Dr. Elena Naumova, who I'm very grateful helped arrange this to come and speak for a moment.
Is it working? Yeah.
Let me just turn this on. No.
Perfect.
Thank you very much. Thank you very much, Ram, and thank you very much to the audience. Those who don't know me, I am a member of Tufts University for 20 plus years, and I started at the School of Medicine, working together with Oren, who introduced me to wonderful world of researchers in India. And that's where I met with Rajiv, who came on the grant we are currently working on as well. I feel it is extremely important to recognize that the work for global health starts in the classroom. It's when you develop your connections, and those connections stay with you for a very long time. You know, it's hard to imagine that we started the work a very long time ago, it was 20-something years ago. And Rajiv was first took my class in intermediate biostat, and then was a TA for that class, for the intermediate biostat. And then when I came to India with a series of workshops, he was helping me all the way to set up a structure and think about more carefully how to deliver this material to students at the CMC. So these connections are invaluable. And I hope all of you will sort of learn that where you start your global health research, in the classroom, building the connections with your peers, with your friends, with your colleagues, and think more about that all our knowledge are transferable through interdisciplinary and intergenerational pathways. So ability to learn from your peers, ability to pass your knowledge to your own students, and ability to learn from your students will make you a better teacher, better researcher, better scientist, and a better human being. So I'm so glad to see Rajiv here. We spent a fantastic time together thinking about next steps and next research, and I believe that you will enjoy his presentation and develop the connection stronger with people who come in here with different presentations. Thank you.
Thank you, Elena, for the wonderful introduction. It's really nice that, you know, as telling Elena, last time I was at Tufts, it was about 12 years back. When I was still a student trying to figure my way around, and then coming here and talking to people here about the work that we are doing currently in the Northeast. It's really a wonderful feeling. And thank you very much for that opportunity, Ram and Dr. Henry and others that you have given me. So I'll just start off with a bit about Northeast India. And why I'm talking about Northeast India is that many of you would have come to India, some of you are from India, but I'm pretty sure that a lot of you would not have, you know, visited the Northeast of India, which is mysterious, mystique, different. I don't know what we say. Even, you know, I never visited Northeast before I joined IIP at Shillong in 2020, which is 4 years from now. And what makes Northeast unique is that it's separated from the mainland of India by something what is called as a chicken snake, which is just a 22-kilometer wide and a 60-kilometer long piece of land. And it shares borders with 5 other countries. 98% of Northeast has international borders, and many of these borders are porous. There's a range of climate and ecosystem characteristics: subtropical, warm with high precipitation, a range of elevation. There are extensive forests, rich biodiversity and wetlands. You name it, you have it. The Northeast comprises of myriad of tribes and ethnicities. Each of them have their own unique culture, their food practices, and unlike the other parts of the country, here the diet in the Northeastern tribal people is predominantly non-vegetarian. And there is a close human-animal proximity. And this makes Northeast India unique in terms of One Health, in terms of doing One Health research, understanding human-animal interactions and disease transmission. Well, Meghalaya, it's one of the states in Northeast India. It is a hilly state, again, predominantly tribal like the other states. To those of you who want to come to India, maybe you should come visit Meghalaya. It's called the Scotland of the East because it has rolling hills, lovely landscape. Some of it is down there to kind of encourage you to come and visit us. The population, it's not very populated. It's a bit less sparser than what is in the rest of the country. It is dense forest cover. That is 76% of the state is forested, and it is on the Indo-Burma biodiversity hotspot. People there predominantly perform agricultural activities or forestry in terms of their livelihood, and there is a mixed farming practice, which means that animals are typically reared alongside raising crops. It's a diverse cultural and ethnic practice, and I'm going to talk a bit about it. Meghalaya has a societal structure which is different from other parts of India in terms it's a matrilineal society. Children get the name of the mother, they get the mother's clan name, and women are the youngest woman in the family, youngest girl in the family is considered the custodian of the family wealth. And of course, post-marriage, men move to the wife's house. That's how Meghalaya society is set. But as far as the seasonality is concerned, also it is known for having the wettest place on earth called Cherrapunji, which gets a lot of rainfall, and the rainy season typically is from May to September, but it gets extended over time. It follows a traditional system of governance. We have something what is called as a Darbar Shnong, which is a village council, which is essentially an assembly of adult males who functions under a traditional headman called the Rangba Shnong, overseeing the welfare of the people and imposing discipline. And this Darbar Shnong was quite prominent during the COVID. They really helped the government of Meghalaya, set up local quarantine centers and so on and so forth. So there's a lot of activities that happens in the Darbar Shnong area. Now coming to malaria, and I'm going to talk a bit about malaria in today's talk. We know that it is one of the most common infectious diseases with an estimated 4.3 billion people, or half the world's population, who are living in at-risk areas. And the transmission is, as of now, in 85 countries and territories. It is estimated that about 243 million cases occurred in the year 2022, leading to about 608,000 deaths. So malaria is still a very much a big public health problem globally. Now, when we talk about malaria, we talk about infectious disease. The first question arises: how is it related to One Health? What makes it a One Health problem, or is it at all a One Health problem? To me, I think malaria is a One Health problem, and it is a One Health problem because it is not only to do with the humans, the vectors mosquito, but it has to also to do with the environment. For example, the household environment, the places where people live around the houses, presence of animals around, because sometimes animals would attract the mosquitoes towards them. So, that kind of a thing. In terms of habitats, larval habitats that people can create while during agricultural activities, if you kind of dig a land and create an artificial pond, there the mosquitoes can grow, or natural man-made habitats, for example, in Meghalaya, where there's a lot of small lakes and streams, there could be malaria happening. And then definitely the rice fields and other things that make it and places where the mosquito can breed, right? So there are these factors that to me, makes malaria a One Health issue. When we talk about Meghalaya, in Meghalaya, the climatic conditions of Meghalaya, rainfall, the altitudes and other things make it conducive for perennial malaria transmission. And over the years, there has been, malaria has been a problem in certain parts of Meghalaya. Recently, it has decreased quite a bit, but traditionally there has been a lot of malaria, and the decline in malaria in Meghalaya happened later than the rest of the country. So it was a bit of a late decline, and as of 2024, the latest report suggests that there seems to be a resurgence of malaria cases are again growing up. So the environmental conditions are all present there, even though cases are not there. And it is a complex phenomena in this particular place because it has both Plasmodium vivax and Plasmodium falciparum, with about 3 to 8% of malaria cases from Plasmodium vivax. And there's one particular district of Meghalaya called the Jaintia Hills where there's a lot of Plasmodium vivax infection. Also, the vectors of malaria in the Northeast is different from the rest of the country. In India, the predominant vector of malaria is what is called as an Anopheles stephensi, whereas in Meghalaya, it is Anopheles minimus or Anopheles dirus. And I'll tell you, in places in Meghalaya where we did our study, and I'm going to come to it later on during the talk, there are other vectors that we also did find. It also has some, majority is uncomplicated malaria in these groups, but there are some unusual clinical presentations that happens, and approximately 10% of the people do have other clinical syndromes. And then we will talk about it also in my talk, where there's a varied acceptance of malaria preventive measures. For example, the vector control measures and other things that happens, there is a varied acceptance of that. So all these makes the dynamics, the epidemiology of malaria a bit complex in Meghalaya. So as I had mentioned that between 2012 to 2015, there was a lot of cases and it came down, and it is largely attributed to what happened was a wide-scale long-lasting insecticide net or bed net distribution in 2016, where the government went to the houses, they distributed this bed nets to the people, and it is largely attributed to that. But we have looked at the data, my colleagues have looked at the data, and what we found was that even before the bed net distribution happened, there seems to be a decline in malaria because of other reasons. So bed net may be a cause, but probably not the only cause of the decline of malaria in Meghalaya. So in this context, this study was set up, which is a Center for Study of Complex Malaria in India, which was funded by the NIH through an International Center for Excellence in Malaria Research grant to Professor Jane Carlton of New York University. And Meghalaya was one of the sites. It was a collaborative initiative with New York University, University of Manchester, and other partners in India. And one of the things about CSAMI, other than looking at the epidemiology of malaria, was also capacity building of young researchers. As a part of the CSAMI, we did community and clinic-based studies to understand the epidemiology of malaria in Meghalaya. Which involved both survey data collection and blood sample collection. As a community-based collection, we did it as a cross-sectional study in 3 endemic districts of Meghalaya, which involved about 1,500 participants, about 3,700 plus participants. And we had a good collection, about 96.5% did provide the blood samples. And what we really did was in Meghalaya, as I had mentioned, the traditional village system, the village governance where we have the Rangbashnong. So we actually had to take permissions for these village councils to do the study, where we had to go in a preparatory visit, meet the headman, talk to the headman, get permission for us to enter the village, to be able to do these cross-sectional surveys. And then we had the village sensitization meetings before we could get into getting the informed consent and completing the data collection that we wanted to do and the sample collection. Right, so these were cross-sectional studies that we had done to understand the epidemiology of malaria in this place. And what we found that, I told that between 2012 to 2015, there was a lot of malaria and it came down. By the time in 2018, when we went, majority of the people, there was very little malaria case in that place. We didn't find active malaria cases, not much of report. But we used PCR-based methods to find out whether the infections are there, and we did find a lot of asymptomatic infection. So what commonly is done in the government programs with malaria is that you use something which is called as a rapid diagnostic test or an RDT. But then RDT, so we found people who were RDT negative, but PCR positive. And this was mostly in 2 areas, which is the Khasi and the Jaintia Hills district. There was another area, which is South Garo Hills, where there was a lot of malaria, where there were still cases of malaria being reported. And there what we found was that they were usually RDT positive. So what it tells us, if you have very low levels of transmission in certain areas, you may not be able to detect malaria using the conventional RDT methods. But if you require a certain level of transmission to be able to detect it, right? So that was one of the key findings that we found, that there was a lot of subpatent infection in places where there were very little malaria reported, but there were clinical infection in places where there were more malaria being reported. We also did a clinic-based study in parallel to the community-based study, where we enrolled people from 3 districts, again, the same 3 districts, and we also got a very good enrollment. About 99% of them were enrolled. And we found 4.4% of those with febrile symptoms of malaria to actually have malaria. And this is again by PCR as well as by RDT. They had Plasmodium infection. And again, as expected, the South Garo Hills area, where there was active cases being reported constantly, had the higher prevalence of malaria. Again, we did find that in the Jaintia and the Khasi Hills areas, it was mostly by PCR that we were able to detect, whereas in the South Garo Hills, we had more RDT positives. In terms of the different types of infections, we found that majority of the infections, as has been reported in Meghalaya, was Plasmodium falciparum. That is what the commonest vector is. As I mentioned initially, that about 3 to 8% is what has been reported to be Vivax. And in one of the places, when Jaintia Hills, we did find Vivax infections that is being reported, and a certain percentage had mixed infections, but it was only one participant who had mixed infections, which is both Vivax and falciparum. So the predominant transmission was mostly from Plasmodium falciparum. That was the predominant agent in these areas. We use the data to run regression models to understand what are the risk factors in a context where there is much less malaria, where malaria is disappearing. And to our surprise, we found that presence of electricity in a house was a risk factor. Now, we usually equate higher socioeconomic status, development with less infections. Why did we find the presence of electricity?
Just to interrupt for 1 second, Rajiv, I've been informed online that the slides were not advancing. So let me just take 1 second and see if there's some way to troubleshoot that. My apologies for interrupting.
That's right, no problem. You can, I think, log off and log in.
No, it's on it. No, I don't think that we need to do that. Let me just see if there's something I was doing wrong here. This is. Are the slides advancing for folks online? Could you let me know if they are advancing for you or not? 17.
Yeah, we are in 17.
Okay. Okay, so we're in slide 17, so they appear to be advancing. Thank you.
Perfect. Thank you very much. Yeah, so where was I? Presence of electricity. Now the question was, why would presence of electricity be a risk factor, right? And we had this discussion, and then the answer was simple. In a village where there is no light outside in the evening, and that is when the Anopheles mosquitoes, go around trying to find their meals. If you have light, it attracts the mosquitoes. And that is why we found that to be a risk factor, right? As expected, of course, we found animals being protective because animals also attract mosquitoes. So if you're attracted towards the animals, you may not go towards the humans. And presence of mosquitoes, of course, it's a no-brainer that it was a risk. We also found certain individual level risk factors, which was that having history of malaria in the past 1 year, there was some sort of a genetic predisposition that they would get malaria again. And if you travel again, because if you're traveling, then you are not really sleeping under bed nets, you're sleeping under different conditions, was also a risk. So these were some of the risk factors epidemiologically we found in this area where there was much less malaria cases than anticipated. Oops, okay, let me see if this moves. Okay. We also did some mapping, and we also tried to find out if we could have areas where there was more malaria happening. We use a simple SAT scan to look at clustering of cases, and we did find a significant cluster in one area in the Khasi Hills district, where we found that there were a few villages where there was a clustering of malaria. So again, and again, as I mentioned, this is in the context of disappearing malaria, very less number of cases. So, there are still these pockets where there is an intense transmission and infection going around. This is what we found. But more interestingly, also what we found was that we looked at serological evidence, whether these children are seropositive. And there are studies which have shown that in places where you have very little transmission happening, serology could be a good marker of infections. And we did find seropositivity, but we also found seropositivity in young kids, which kind of reinforces the fact that although we are not detecting in terms of the RDT, there is still undetected transmission going on. People are getting infected. And that is important in terms of malaria control, because once these intensive efforts of control is taken away, and then there could be a chance of resurgence, because of course the environmental factors and the vectors are still present. So that is something, and we presume that if we can have a transient serological marker, that could be a good indicator in terms of repeated surveys to look at whether there is still transmission ongoing or not. So that is one of the things we thought would be important. We also were asking about in terms of why is there so less cases. I did mention about the insecticide treated net being given in 2016, and then the cases coming down. Was there a correlation? And one of the important questions when it comes to epidemiology or any kind of an intervention is that we can distribute the insecticide treated nets, but people may not use it. And if people don't use it, then it's of no use in terms of reducing transmission or bringing down the number of cases. But in this case, we did find that a lot of people did use the insecticide treated net. So there was a lot of use, and that again kind of reinforces the fact that probably that is one of the reasons that the malaria came down, because people were really using these nets. Vector control is the mainstay for malaria control, and other than the insecticide treated net, one of the things that is done is an indoor residual spraying. You go to the house and you spray indoors to the house, and we did find that there was much less acceptance of residual spraying, and we have done some qualitative studies, and I'm going to come to it later about what could be the potential reasons for that lack of acceptance. But this is important because the insecticide treated nets that is being used, the insecticide that is used to treat these bed nets, pyrethroid, and there are already reports of pyrethroid resistance globally, and that could reduce the effectiveness of these nets over time. So this was in general the epidemiology of malaria. We found subpatent infections, we found seropositive seropositive cases in children, and we did look at the risk factors where we found certain important risk factors for malaria in this neighborhood. But again, I'm talking about One Health, so this is just a part of it, right? So what else would impact transmission? And that is one of the important things with malaria is the vectors per se. And I did mention that the Northeast has the unique vectors. And this work was done in collaboration with Kathy Walton from the University of Manchester. And what we started looking at is we said, okay, let's identify what are the predominant vectors in this region, right? So what could be the common vectors that is being transmitted, given that we know that from previous reports that in the Northeast, the vector density and the vector profile could be different, right? So we did some entomological work to look at the vector identification, and we did it using molecular methods. So we tried to ID using PCR-based methods. And during our collections, what we found was that there was a good species diversity. We found 24 different species of Anopheles in the collections that were done over a period of 3 years in that place. And as I did mention that Anopheles baimai, Anopheles cuneiformis, and minimus were the predominant vectors. In this case, in our areas, we didn't find that much. Instead, we found Anopheles cerovulmeri, Anopheles maculatus, and Anopheles japoriensis to be more common, which are more in tune with what is seen in Southeast Asia than with the rest of the country. And that makes intuitive sense because, as I mentioned, Meghalaya and the Northeast India has borders, international borders, and one of the international borders is with Myanmar, and there's a lot of malaria in Myanmar. And people and vectors do move across. So it kind of made sense to us, but this was something that has not been reported to the extent of what it should be reported. And we also identified 2 new species, Anopheles dissidens and Anopheles zui, which was not previously reported from India. So these were some new vector species that we reported. And majority of the vectors were from rice field collections that we kind of found. I did mention about doing morphological IDs. So we did a small study where we looked at so what is commonly done in entomology is people look at the mosquito and they try to identify morphologically what species it could be. And I did mention that we use molecular IDs. So we did a comparison between the morphological identification and the molecular identification. So we used entomologists to look at the morphology, and then we did the molecular testing to look at it. And what we did find was that there was a lot of misclassification when we do morphological IDs. So certain, for example, Anopheles culicifaces and minimus they were mentioned during the morphological ID, that these are Anopheles. So what you see here is the morphological IDs, and what you see is what the molecular identification is speaking. So what was mentioned in Anopheles culicifaces is actually not Anopheles culicifaces, but something else, right? So we did find these differentiations, and that has to do with the fact that sometimes it is difficult to morphologically differentiate between 2 species of Anopheles. Molecular IDs are more accurate. Also, when we learn about the epidemiology of malaria, we know that, the biting time, when the mosquitoes come and bite humans, are very important. And we know that Anopheles, what we have learned from at least from what I remember, is the mosquitoes which carry the malaria parasite, the Plasmodium parasite, bites late in the night. So we went back and see, okay, let's see what the biting behaviors of these mosquitoes are. And then we did some studies looking at the biting behavior, both within the indoor and the outdoor. And we didn't look at biting per se, but we looked at the density and tried to figure out where we would see the maximum concentration of the mosquitoes. And we did find that there was a shift. Previously, it is supposed to be late in the night. That's what traditionally the textbooks tell us. But here we found that the peak biting time, the mosquito densities were between 6 to 7 p.m., which is evening when people are outdoor, not in their bed nights. So that means that these mosquitoes have a higher chance of biting a host, right? So that is something that we found. And this is something that we are not the only ones reporting. Now, there are current studies which are actually reporting that mosquitoes, the biting behavior of the mosquitoes may have changed, right? It's to do with food, I guess. When you don't find food in the time that you're supposed to find, you try to figure out when you can find, and probably that's why the mosquitoes are changing their biting behavior. But we also did find that the biting behavior is also a bit different by certain species. For example, in the outdoor setting, there were, for example, Jayporiensis and Pseudo-Ilmeri, they remained active till the midnight. So there were some sort of a differentiation in terms of the species. The other thing that I did mention initially was resistance to insecticide-treated bed nets. Now, this is not being reported widely from India, and one of the interests was to see whether we could find insecticide resistance in some of the mosquitoes that we did. So we looked at something what is called as a KDR resistance to DDT and pyrethroids, and we did find an evidence of insecticide resistance in the mosquitoes in Meghalaya. Now, again, that is important in terms of the public health, because if the insecticide resistance is more prevalent, then that would mean that the LLINs that is being distributed would be less effective. And as I did mention that people were not really using other methods, for example, IRS, so that could lead to a resurgence of malaria in these areas. So that was some of the work that we did in terms of the entomology. So we looked at the epidemiology part, the entomology part, but then we felt that there is something else that is missing, that is behavior. And a lot of times in public health, we do not really account for that behavior. We kind of take it for granted, but that becomes very important. One of the things I tell my students when I talk about that is during COVID. In India, we were all asked to wear masks, but many of us had found reasons not to wear masks for whatever reason be it, right? So that is typically what I think is human behavior. And we did some social and behavioral studies to help understand what is the barriers in adopting the current practices. For example, I mentioned people are using nets, bed nets, but they're not allowing the malaria control program to spray their houses and what could be. But then also we know that a lot of times in the programs, what is being reported may not be what is done. For example, I could say that, oh, I gave this tablet or I distributed this bed net, but in reality, that has not happened on the ground. So we also did some observations to understand how the program is doing and what they're doing. And we did observations of IRS and LNIN implementation in some of the villages. But we also did a lot of qualitative studies to understand knowledge, attitude, and practices within a community setting in terms of what they felt in terms of malaria. And more importantly, one of the interests, and this is by one of our colleagues and collaborators from University of Manchester, Elisa Bellotti, was to understand social networks. Who people talk to, who people do not talk to, who people would listen to if you're talking about a particular intervention or behavior, so that we could then target, gatekeepers. A lot is being talked about in terms of community gatekeepers, key people, and so on and so forth, and how important they are is what was one of the other interests. So very quickly, we did find that that the LLIN distribution was really happening very well. The government was really taking the effort to go out and distribute the LLIN. So there was, even in these remote areas, so that was wonderful to know. We also did find, as was reported in the epidemiology part of it, that people refused household spraying, and there was a lot of reasons for that refusal. For example, some of the things were like people didn't like the smell of the DDT, which was being sprayed. They didn't like it. They felt that if children are there in the house and you spray this pesticide kind of a thing, that could harm the children. So there were some of the reasons, but there were some reasons which were very local. For example, one was in those areas, people do raise these bees for silkworm, right? And they felt that this could kill the silkworms, and that was a livelihood issue, and that's why they refused. So these were some of the very other local things that happened, and I think this is important again for a program to understand it, because some of these has to be countered or has to be really worked out. So that was some of the things that came out. There was also, we found that there was a shift in the community preference in terms of the malaria treatment, right? Traditionally, again, there was in Meghalaya, we have something which is called as a traditional doctor, which people go to, and they go to that person for all the treatments. But somehow for malaria, there has been a shift over time, and people did mention about it that previously they used to seek traditional medicine for malaria, but now they are going to the public health system. And this is also what we found when we looked at the health seeking behavior, that there was more utilization of the public health system rather than the traditional medicine system in most part, except in South Garo Hills, where there were some still people seeking traditional healthcare. In terms of social network analysis, as I was mentioning, this was done with the Elisa Bellotti, where we looked at the malaria prevention measures and who listens to what and where we could. So basically identify key opinion leaders whom we could then target to deliver some of the health interventions. And what we found in this setting is that the individual's adoption to malaria prevention measures, people who would listen to in terms of malaria preventive measures, were mostly people in the households. And we didn't find much effect in terms of the opinion leaders. So that was something that was what we felt was a bit new to us, because we always in public health messaging communication, we target opinion leaders, and here it is where the system in which the information is passed and on is kind of a bit different. And that is again something that should be taken into account in terms of the public health programs. So this is some of the work that we did in malaria. We looked at it from the epidemiology perspective, from the entomology perspective, as well as from the social behavioral perspective, which I felt was quite neat because it's like a 360-degree overview of the disease, and it could then feed in to the program, not only from the epidemiology, but also what can be done in the terms of the community perspectives. I'm going to quickly move on to some of the other initiatives that we are doing in the Northeast now, that we got recently funded a couple of years back by the DBT India Wellcome Trust India Alliance to look at zoonotic and vector-borne disease center. This is a research and training center with the aim to establish and foster a ZVBD training center to characterize and evaluate risk patterns of regional zoonotic and vector-borne diseases. And we're targeting 6 diseases here: scrub typhus, Japanese encephalitis, leptospirosis, brucellosis, H1N1 influenza, and cryptosporidiosis, and to look at disease trends and transboundary animal diseases. So there are different studies that we are doing for this. We started with an initial census of 30 village clusters in 3 different districts. We are doing an environmental mapping. We completed a cross-sectional serological survey to understand what are the seroprevalences of some of the common zoonotic vector-borne diseases. And then we are also looking at qualitative studies, understanding the socio-cultural and behavioral risk factors. And we are hoping that we could then put everything together into a transmission model to understand the transmission of zoonotic vector-borne diseases in these areas. This study is being done in 3 different districts, and which has 3 different ecological profile. One in the East Khas Hills is actually bordering Bangladesh. It's a plain land. Ribhoy district is bordering Assam, which is a neighboring state. And then we are doing one inland, which is in the East and West Khas Hills district. As with the malaria study, we are going around with permissions from the headmans and then having community meetings to kind of start the study. We do have some initial results from our serological data, which shows the seroprevalences. For example, the scrub typhus, which we traditionally people have been talking about it, but not really documented. We found a 12% seroprevalence of scrub typhus. But most importantly, for leptospirosis, we found about a 9% prevalence of leptospirosis, which is not reported from Meghalaya. Now people are talking about sporadic cases of leptospirosis, but from our serological data, looks like there was leptospirosis present. And then we can also see heterogeneity in terms of transmission. It's not that it's present at the same level at all villages, but at different levels. We are also looked at awareness, and we found that there was low awareness about zoonotic disease, and there was lack of veterinary oversight. There's a lot of backyard slaughtering that happens in Meghalaya, and many of these backyard slaughtering animals are slaughtered and consumed within the village without proper veterinary inspection and so on and so forth. That predisposes people to the risk. Now, people know about animal diseases, people know about human diseases, but the link that some of these animal diseases could be transmitted to humans is something that is not made. And just for those, if any of you would be coming to New Orleans next year, next week, I've put this here, we are doing a symposium where we're going to talk in more detail about this. This is my sales pitch for the symposium. So in case you are there in New Orleans, please come. It's on the 17th of November. So that is something that we are doing. Also, we are looking at epidemiology of soil transmitted helminths, and we are looking at it from the zoonotic helminth perspective, because again, when we talk about soil transmitted helminths globally, there's a lot of effort in terms of this helminth control, and one of the common ways is to give albendazole and looking at human helminths, but less is known at zoonotic helminths. But there are data to show that there could be zoonotic helminths that could affect the humans, as well as there could be animals could be mechanical transmitters. So we are kind of trying to understand that. And we did a small study with 274 people in 3 areas, and we did find Ankylostoma solanicum, which is a zoonotic species. We did find Ankylostoma solanicum in humans as well as in animals in this area. And most importantly, what we also found is that there were only 4 cases out of 270. So it's not a lot of cases, but looking at the data in terms of individual level, we did find that 3 of the 4 cases had an animal present, and in each of the 3 instances, the animals were also positive. So there seems to be some sort of either a common source infection or some sort of a cross-host transmission. We don't know, but it is worth exploring. So these are some of the other initiatives that we are doing in Meghalaya. I'd be very happy to talk about it, and if anybody of you is interested to come and spend some time with us, do some small studies, more than happy to have that conversation as well. Now, doing and working in Northeast, how beautiful it is, but it also has its own challenges, and no talk is complete unless we talk about the field challenges. So let me just outline some of them. So one is refusal to participate. Our refusal rates for getting a serum sample, a 5 ml blood sample, is about 50%. 50% of the people say no, and that has to do with traditional beliefs regarding blood collection. People think that we could do some things with the blood, black magic, voodoo, I don't know, and it's sometimes challenging to convince them that we are not doing. But also there is a negative past experience. One of the things we really found was people were really interested. When we said that we want to test your blood for ABCD, they wanted to know what the results were. And they told us specifically, we're giving this sample, please tell us whether we have a problem, not have a problem, whatever it is, give us the results. And when we're talking to people, especially when we're looking at refusals, one of the things was that there's a lot of NGOs which has come taken samples, done some things, but they never told us what they found, right? So one of the things we are building into our research is to go back to the communities and to inform them about what we found. Of course, keeping in mind that confidentiality is an issue. I can't go and say, oh, you were positive, and you were positive in front of everybody, right? But I can at least tell that we took data from 20 people and we found that 5 of the 20 were positive. So this percentage of infection is happening, and give them the results in a broad sense. And that is a part of our community outreach program that we are building into our research. And we think that that could help us buy in with the communities. The other challenge we felt was the collection and transportation of samples. That is something that is not thought of. We collect the samples and we transport it, but then the samples has to come in a particular way, right? You have to preserve it in 4 degrees. It has to go to a minus 20-degree freezer within a certain number of hours. And here we are working in these remote areas where it takes me a day to bring the sample from where we are collecting it to my central lab in Shillong, right? We have a fridge. There are power outages for 3 days, 4 days. There's no power. What do we do, right? So these were some of the things that we faced, and we really had to, come up with solutions on the fly. We had issues where we are supposed to transport the sample, let's say, for example, twice a week, and then we suddenly found there's a power outage and we had to do a daily sample transfer. And that increases the cost, that increases the other things. Also, what happened was that, how would we transport the samples? If I'm using my own vehicle, it is expensive because of the terrain. So we used to actually got into using local transport systems who would then be used to transport the samples. We would create kind of a logger where we would mention what all samples are coming, put it in a ice box or something, give it to the local transport system, and someone would collect it in Shillong, and we had to really coordinate all that. So that's a lot of operational effort that goes in. Most importantly, these are difficult areas to reach. For our malaria walk, our field team had to walk for 6 hours with all the equipment in these road conditions to reach the village, because where you have the disease are usually the places which are much more remote. So these were some of the challenges that we faced, we are still facing going around. But I do hope that the effort that we put in, the results that we get is worth it. And here I'm going to stop. This is a team from IAPH Shillong. And thank you very much again for this opportunity.
Thank you, Rajiv. And thank you for leaving time for questions, which I'm sure we'll have a lot from the audience. I'm just going to start off with 2, if that's okay, related to each other. One is around, you talked about humans, the vectors, and then the third is the environment for One Health. And for me, in work in, say, urban informal settlements in India, one of the major challenges with malaria is water storage, right? Because the household level water is not accessible. Almost, large proportions of India, water has to be stored before use because it's intermittent water supply, or you're collecting water from stream. To what extent is that playing a role in malaria transmission, and what are strategies to address that, the fact of stored water as a mode of water access? And the second one is going to be a broader one, it's related, which is around malaria elimination, right? So I think you've identified, you're working in a place where malaria is on the downtrend, but then there are these broad questions about how do we eliminate it when the vector will not be eliminated. I'm wondering what you learned from this, and then I'll hand it over to the audience.
Yeah, thank you very much. I think wonderful questions. I think in terms of water, it's not only malaria. I think it's also to do with dengue and other vectors where water storage is an important issue. Meghalaya, it's a very strange situation, right? We are in an area which is the wettest place on earth, so we get abundant of rainfall, right? We probably get rains. And although I did mention it is from May to September, but it's actually, you have rains even in April and it goes on sometimes till October and things like that. But then we are also in a place, for example, Shillong city has an acute water shortage. We have to buy water in Shillong city, many houses does. So, we have this because there's no concept of preserving water. It rains and it flows down the hills. But I think it is important because that is something that would, these small puddles of water is what would result in the vectors breeding in those places. And we did find a lot of vectors in the rice field and other things. And I think it it is important to kind of educate or work with the communities to kind of take care of that, which I don't think is happening to the extent that it should happen. But that is something that definitely we should think about. Your second question was in terms of
Malaria elimination.
malaria elimination, and I think that's a $1,000 question, because, and I totally agree with you. You know, we are seeing a reduction in the cases, but the vectors are very much present. The environmental factors are present, and we really do not know how much of those sub-patent transmissions or subclinical transmissions going on. Now, I did mention about sub-patent infection, but one of the questions is that, is it sufficient to transmit? Because you need the gametocytes to be able to transmit, and we don't have an answer for this in this particular study, but it is worth looking at it. What is the contribution of sub-patent infection in terms of the transmission in these areas? That is number one, and of course looking at these pockets of transmission. And I think those are some of the things that will define how the control program will work or not work. I did mention that there's already in 2024, there is an increase in the number of cases in some places. South Garo Hills was one of the last bastions of malaria in Meghalaya. It brought down the number of cases, but again in 2024, there has been an increase in the number of cases. So I think these are the things we need to keep in mind. And any type of an environmental surveillance system that we can bring in to be able to look at how we can to kind of monitor what is happening would be very important.
Hi, thank you for talking today. I know you mentioned that there were some barriers to your research, especially in terms of community-wide and sociocultural perceptions, and so I'm very curious, one, what you think you would do in terms of strategy, in terms of incorporating community engagement, and two, what that would look like in your future work in terms of future interventions or future studies.
I can tell you what we are doing, right? Because we are already doing it. As I mentioned that, when we do public health research, involving communities, getting the buy-in of the community is very important. Because unless we have the buy-in, it's not going to work. Any kind of an intervention we say, any kind of suggestion we give is not going to work. So first question is, do the community members understand that this is a problem? Right? Because their whole perception could be very different from what we think is a problem. So I think we start off with engaging the communities in the very first instance, kind of providing evidence to them, right? So this is what we are seeing, and then we are working with them to try and come up with solutions that they feel will work. That is one thing, and of course, as I mentioned, that when we are getting the results, we're also providing them the results, we're giving them the feedback. One of the work that I didn't present, we'll just be starting once we go back, is a risk communication strategy on vector-borne diseases. And we are proposing, or we are planning to work with the community to understand their risk perception, to understand the communication tools that they use, and to work with them to develop a risk communication strategy which we feel would work in these communities. Because a lot of times what happens, especially in communication, risk communication is one of the areas where we design something which is very top-down, like prescriptive, and to a community it is not relevant, and it is therefore not acceptable. So those are some of the things we are doing in terms of working with the communities to come up with solutions that we feel are locally relevant.
We have Professor Ward, and then we'll have a question. Rajiv, if you could, is the video on you from this side?
Yes, I think it is pointing towards the...
Okay. All right.
That way they can see you.
Rajiv, thank you for that great talk. You mentioned briefly cryptosporidium, but you didn't say anything about it, and I know you've done a lot of work on cryptosporidium. It was part of your PhD thesis as well. So what's the prevalence of cryptosporidium, which is a One Health pathogen, and is there any relationship with malnutrition in children, especially in Meghalaya?
So, we are still looking at the data. I didn't mention about it because this was a part of the zoonotic and vector-borne disease study. We're still looking at the data. I just got the data some time back, so we have to kind of more work to do. And this was this was a cross-sectional study. So, I think from the top of my head, I think we found about 5% children with cryptosporidium, if I'm not mistaken. But we have to really look at the data and analyze it more closely to find out. And I do agree with you, because this is a community which is there's a lot of pigs, there's a lot of cows and other things in these neighborhoods. So we could expect some of the zoonotic species to be more prevalent here, and it'll be really interesting to look at it. In terms of malnutrition, you asked a very important question, and we have not really looked at that in this particular study context per se. But one of the things in Meghalaya is the level of malnutrition is quite high in Meghalaya, and we know that the prevalence of diarrheal infection is also one of the highest in the northeast for Meghalaya. So, and again, coming back to crypto from the work that you'd mentioned in Tamil Nadu, we also know that it's one of the second commonest pathogen, diarrheal pathogen. So I do expect that we're going to find more crypto, except that probably we have to do more focused and studies around that. Thank you.
Hi, thank you for coming to talk to us. You mentioned that there's been a shift for people with malaria seeking like traditional doctors to more like preventive or public health efforts. So I was wondering what exactly are the options available for treatment of malaria? It seems like there's maybe a lot of challenges with the lack of health infrastructure too, so maybe touch on that. And then also just in the greater psychosocial work, patient preferences, and how is medication adherence, the patient strategies, how that affects the treatment.
Preferences are very limited, to be very frank. I mean, in Shillong city, yes, you have private providers, you have the government healthcare system, the government hospitals and clinics. You have traditional, Ayush is something that, Ayush practitioners is something that is traditionally quite prevalent in a lot of places in India. You have Ayush practitioners, and you also have traditional healers, which is what is in Meghalaya. But I think in the villages, you largely have to depend either on the traditional healers or on the government system. There was a lot of outreach from the government that had happened in terms of the malaria, and one of the things that the government did was, so we have a frontline health worker called the ASHA, the accredited social health activist in India, who are the frontline health workers who are from the village, from the same community. And I think the government has empowered the ASHAs to do the malaria testing, and then in consultation with the medical officer to provide anti-malarial drugs. And I think that ease of getting it kind of brought in a bit of a shift, and also the fact that there's a lot of disease and deaths that they say brought in that shift. Because one of the challenges, and I can totally understand that, see, majority of the people are, as I mentioned, are agricultural workers. People do agroforestry kind of work. So if you have to go to a particular clinic to get the medicine, it's 1 day of work loss, because your travel time is really a lot, right? And that means 1 day's, less wage or whatever it is. And so that is why people would really not prefer that. But once you make that healthcare available closer to them, then it is, the access issue gets taken care of. And I think it's largely to define with what the access could be. So I think that has probably been one of the reasons why the shift has happened, at least for the malaria, because the access was made easier.
Any other questions from here? Okay, we have 2 other questions. Maybe we'll take them both at once, just because we're running up against time.
Hi, thank you for coming. My question in regards to One Health is how climate change might have been impacting the transmission of malaria, or also just the reproductive cycle of the mosquito itself, and see how that might impact everyone.
Yeah, we haven't looked at it. Sorry, go ahead, please.
Yes, sorry, 2 at once, sorry.
Thank you again. I was wondering about the community engagement aspect, and I remember you mentioned if there's 5 people out of 20 who are positive. I was wondering first, are those 5 people told that they're positive? And then second of all, what are some barriers for seeing everyone again and telling them the results, whether it's positive or negative?
Yeah. So I'll start with the question in terms of climate change. I mean, we haven't looked at it from the perspective of this research, but it is important because I was talking to some of my colleagues some time back, and for example, this year we have had a quite erratic climate in Meghalaya. I mean, for that matter here as well, I guess, when I came to Boston, I told people it's unusually warm. All the warm clothes that I brought, which is half of my suitcase, could have been left back in India. but never mind. I mean, over the years, what we are seeing, over this year at least, what we saw was short spells of intense rain, followed by moderate spells of really warm weather. And those changes could result in different disease dynamics. For example, you could have more mosquitoes growing and things like that. Even Shillong was warmer than what it used to be, so you would also have it go to a different region, and that is something that has been studied globally. So I think looking at it from that context will be important, and also from the epidemiology perspective, it is important because traditionally some of these people would not have been exposed, so they are more vulnerable, right? So I think it makes a lot of sense to look at it. We haven't looked at it from the perspective of that research, but definitely, yes, that is something that is of interest. Your question was on, sorry again? That's the problem, right?
The communication
Yeah.
aspect, so,
Yeah. So two things. One is that we do. So we do go and tell the individual people, because that is the confidentiality. We tell only them that yes, you are positive, and if they have to do something for that, we encourage them to do it. But again, within the context of our research, what we're doing, many of these are sero surveys. We're looking at IgG markers. We really don't know when they got exposed, and they probably do not have the active disease, and we have to be very careful of how we communicate that risk. Because when we tell them, oh, you are positive, the first reaction is, oh, I am diseased. And you are not diseased. You are just exposed at some point in time, maybe had a mild infection at some point or an asymptomatic infection, you are fine. So we have to communicate that risk. But to the community at large, and we're talking about communities where everybody knows everybody and everybody knows everything about everybody, right? So I was talking to one of the senior health officials when I initially came to Meghalaya, and I was talking about in the context of COVID, and we were asking about confidentiality, and he looked at me and said, Dr. Rajiv, don't worry. Everybody knows everything. In fact, everybody knows too much of everything, right? So that is the context we're talking about. But as researchers, we have to be careful about how much we are talking, because some of these diseases also come with a taboo, right? They have a stigma attached to it, and we do not want people to get stigmatized, people to get isolated. We can say that, oh, this is a zoonotic disease you have, and then it could have other repercussions. One of the things I realized when I was we're doing our research on this zoonotic and vector-borne diseases, zoonotic diseases are, for us humans, it is illness, it is sickness. But for people, especially in a context of mixed farming or agriculture, it is livelihood. You are sick, you're getting the disease from your livestock, which means that I may not be able to sell my livestock in the market, which is a source of income. And that is an extremely sensitive communication. So, we really have to kind of think about how we communicate this risk and messages. And in a way, sometimes we do brainstorm to figure out what would be a good way of communicating this without antagonizing people.
All right, well, thank you so much, Rajiv, and thanks to everybody online for attending. So, just amazing work looking comprehensively at the epidemiology of malaria in a place where it's on the downturn but could at any time have a resurgence, right? So I thought that was a really beautiful example of One Health and the importance of One Health and thinking broadly about a problem. Our next Global Health Seminar will be in January. We have some inklings of things in the works for that, potentially on avian influenza and global transmission of avian influenza, or something else. So please join us on that front, and thanks everyone for attending the Global Health Seminar today.